First of all, most of you work with epilepsy, so I'm sure that you know a lot about epilepsy. So what can you tell me about epilepsy? Classification, how do you recognize someone has epilepsy? What do you do?
So there's different types. You can have complex partial seizures, you can have tonic-clonic seizures, you can have absent seizures.
Yeah. And so then goes into the classification into partial, complex, simple, and all of those things. And then what do you know about non-epileptic seizures?
It presents itself as a seizure, but it's not organic in the brain.
Okay, interesting. We will see that. Okay, what else do you know? If it's not in the brain, where is it? In the soul? In the heart? In the cardiovascular system?
It's not to do with an electric discharge within the brain.
Okay. Good. Anything else? No? That's fine. I mean, I'm not expecting you to know. I'm just challenging different things because there are concepts and things that what we're saying is not electric discharges, which is true. We don't see it in an EEG. But then, does it come from the brain or come from somewhere else? Or is it a combination of things that come from? Yeah, and we're going to explore that a little bit more. So these usually were the things that you know about epilepsy, the ones that we usually are more familiar with, that you have focal, generalized, complex, simple, and then usually the area of origin, where they're coming from. And then most of the time you have tests to kind of help you with the diagnosis, because some of the patients that you said present like as if they were having epilepsy, but actually we cannot find with these tests that actually they fulfill the classical classification of epilepsy. Yeah. So you have blood tests. Do you do prolactin levels ever here? We do it in neuropsychiatry. We do it quite a lot. Sometimes when you try, we used to do it. I don't know if they're doing that often, but when I was a trainee, the prolactin levels go high when you have an epileptic fit, but actually don't change when you have a non-epileptic fit. So it's another tool to help you, particularly in those cases where actually you are not sure, because actually the patient has such fits that actually it's difficult to differentiate if they are epileptic or not. So you have tools like that, like prolactin levels, you have the EEG, that you will have the electric activity, that's some of the things that we look for. And then most of the time we ask for brain scans. What do we ask for brain scans? What are we looking for?
Any lesions that could be the cause of it.
Exactly. We're trying to find the structural change. Many of the patients don't have any structural change, isn't it? But they may have a tiny thing or nothing, but then the EEG will show that actually they do have epilepsy, right? However, despite all of these things, we do know there's a percentage of patients who may have all of this normal, but actually the classical presentation that they have is epilepsy. So we are guided by the clinical presentation. And because we do know that about 5 to 10% of the EEGs may be negative in one single test. So repetition actually helps sometimes, or longer records help sometimes. Okay. And what the NICE guidelines recommends that if you have someone that you suspect epilepsy, they should be seen by a specialist clinic. Yeah, someone who actually has seen them several times, because epilepsy can be kind of tricky. It presents in different ways. It can present with an anxiety attack sometimes. It can present with people fainting. It can present with abnormal movement. I think that the general population think that the epilepsy is just the tonic-clonic ones, isn't it? And actually that's why you need to, when you suspect it, send it to someone who is a specialist, particularly as a neurologist, who will actually be able to say, does it make sense from the clinical perspective that this could be epilepsy? Yeah? Any questions? Are you familiar with all of these things? I think that you do these things almost every day, don't you? So the interesting thing that what we have found out in several studies, that many of the patients that go to the first epilepsy clinic, 1 in 5 will have non-epileptic seizures. So it's quite a large number, and 20% of your consultations means that the people who were seen in ED or were seen by our colleagues who say, actually, this looks like epilepsy, let's send them to the epilepsy clinic, like the NICE guidelines recommends. 1 in 5 will have non-epileptic seizures. And that is, one, with the clinical diagnosis, two, with the help of the EEG and MRI most of the time. Those are kind of the standard things that neurologists tend to ask for to confirm the suspicious that actually they have or they don't have epilepsy. But most of the time when I receive the referrals, they said, I just sent for an MRI to rule out or to help the patient to come to terms that this is non-epileptic seizures. So every patient, most of the patients, I would say, will have an MRI and EEG, despite the clinical evidence or what the clinician, the neurologists think of it. And we have had a couple of surprises sometimes. So. And then the non-epileptic seizures can be divided into organic and non-organic. And that's hence my trick on you to say non-organic, because actually there are some epilepsy or some abnormal movements. We tend to classify it as a big bag of epilepsy, but actually that is not epilepsy. That's abnormal movements or non-epileptic seizures that can be hypoglycemic, or they can be alcohol withdrawal, or they can be, for example, we have a patient with hyperthyroidism who had one seizure. So, there can be other factors that are very organic, but they're not related to what we call epilepsy. They are seizures, but not epilepsy. And then you have the non-organic, and I put question mark here, and we're going to debate that a little bit more. There are the neuropsychiatric ones, that we are going to put more emphasis on. Any questions so far? Do you see many patients with organic non-epileptic seizures? We have seen a number of patients who have encephalitis, for example, and the first presentation that they come with is with a seizure, and that's most of the time what triggers all investigations. When they have a seizure, they have a change in personality, then they have a seizure, and they do all the investigations, and they found out actually that they have encephalitis. Then they may develop epilepsy or not, but actually the first diagnosis was not the typical idiopathic epilepsy. It was secondary to the encephalitis. But you may see more of those. So again, for the physical organic causes, you can have syncope, which is another thing that actually we try to work with the neurologists, particularly blackout patients who black out in particular fall. We try to see if there is an ECG that we need to monitor, if there's anything else. Then you will have vertigo, parasomnias, other movement disorders that may simulate that they are having a seizure. And then you will have all the endocrinal and metabolic things that I mentioned, and then the drugs and alcohol that you may not see very often, but those of you may wander around ED, we see some of them in ED when they're withdrawing. And there's another debate, do we treat it or not as an epileptic seizure or not? And then we have the psychiatric disorders, which is the one that I'm more familiar with or work more with. And from them, you have to differentiate again those who are other psychiatric disorders like panic disorder or psychosis. With psychosis, there is a huge overlap for people who have abnormal movements that may not be epilepsy. With panic disorder, you all know people will shake and they will describe abnormal sensations like deja vu or things that actually make you confused. Could this be an aura? Could this be something related to epileptic attack or not? And then you will have patients with ADHD. Have you ever seen someone with ADHD? They just suddenly run into the traffic, and you can have some epilepsy presentation where people have this automatism where actually they are quite impulsive and do things. So things that to make you think beyond the epilepsy. There are other factors. Of course, each of these things have other criteria to fulfill having ADHD. It's not just running in front of the traffic impulsively. And then you have depersonalization disorder, patients who actually have these dissociative states where, or sometimes we call it fugue, people who will disappear or not know where they are or will appear somewhere else. And then you will have the dissociative seizures, or wrongly or rightly called non-epileptic seizures. I usually don't like very much the non-epileptic seizure because it's almost telling the patient you do not have that, but you're not telling them what you have. The name in itself is a little bit difficult for them to grasp it. So dissociative seizures explains a little bit more the neurophysiology of the phenomenon. And then you have the fictitious disorder. Does anyone know what fictitious disorder is? No. Okay. Do you know any difference between fictitious and malignant? Okay. I'm just mentioning these things because sometimes I do receive letters, not from neurologists, from other colleagues who actually there's a confusion between fictitious, malingering, and dissociative seizures. Most of the time, the dissociative seizures patients do not have any awareness of the reason why these seizures happen at all, and they don't know what event or what circumstance that may have triggered having these seizures. The fictitious disorder, the patients may have an unconscious wish to be cared for, and actually the seizures happen, but actually they are more conscious that they are asking for help. Yeah, they come. It's a tricky differentiation, but usually we don't. It's very difficult to diagnose fictitious disorder, particularly in this setting, which is acute and quick. And you have to have more evidence that the patient has been asking for care in not one area, but in more areas than just epilepsy. And the malignant is actually someone who actually does it because he wants to gain something out of it, and it's an intention. And you can see that actually when they're outside, everything is fine. As soon as they're in hospital, surrounded by healthcare professionals, all of these symptoms that outside were absolutely fine are not. And most of the time, that is actually some insurance claim or something else that they are trying to gain access. That's why it's called malignant. And the word is not very nice, but it's coming from that idea that actually the person is trying to deliberately show a symptom to gain something, which is not the case of dissociative seizures and fictitious disorder, which is very important to differentiate.
Disease with Munchausen disease and Munchausen by proxy.
Yeah.
Similar.
Well, that's fictitious disorder. Those are mothers or patients who actually are eliciting care, but with an unconscious need of needing care. And it's a little bit more complex. These are usually coming from families who have never cared for them, and then the health system have provided an environment where they feel cared for. So then they start manipulating some of their tests or doing things to their tests to elicit help from professionals. So anyway, let's not diverge into too much psychiatry, but just to be, and I'm saying the things because it is important to understand that patients with dissociative seizures are not making it up, are not coming here to say actually provoking the seizure in the middle of here. And we'll talk a little bit more about this. Any questions? No? So, the dissociative seizures, which are the ones that we are going to focus on today, I put NES because it's non-epileptic seizure, because most people are familiar with that word. I think the Epilepsy Society has leaflets where they call non-epileptic seizures, and I think we are trying to change that for dissociative seizures. I think it's more a positive diagnosis rather than a negative diagnosis. Negative in the sense actually lack of. So what we know that most of the time happen in women. Doesn't mean it's exclusive of women, but actually it's more common in women. And it tends to happen in the early 20s. Sometimes we do have onset of people in their 40s and 30s, and that's related to a new trauma or something that happened in their life where they were being stable and contained, and then there is a new event and these patients start developing non-epileptic seizures. But when you look at the history, and that's where you see my letters most of the time, I spend a lot of time trying to understand the person's personality and how they have coped with difficulties in life, because they may have coped well and been able to work and so on, but there has will be a struggle or some difficulties going on, then something happened, and then we have these episodes. So, and then they said that some studies in the past used to report that it was more common in people with emotional state personality disorder or other type of personality disorders. Other studies have demonstrated actually there's no difference between people with epilepsy and non-epileptic seizures and the personality traits. So it doesn't really correlate that strongly to having an emotional state personality disorder. And that's what I mentioned, I think, because most of the times it's this thought that actually, well, they are emotionally dysregulated, they cannot cope with emotions, hence, this is part of all phenomena. Sometimes it does, sometimes it's overlap in the same way it overlaps with other things, but sometimes you have just pure dissociative seizures, has nothing to do with how the person deals with general life and doesn't have a personality disorder as such. Yeah? May have some personality traits like all of us, but doesn't make it a disorder. Yeah. So, one of the things that it is important that when we diagnose non-epileptic seizures or dissociative seizures, is a diagnosis of exclusion almost. You have to first rule out that the patient doesn't have epilepsy. Hence why the patients come through the first epilepsy clinic and then they are referred to me when there is a suspicious. And sometimes we do it almost in parallel when the neurologist has a strong feeling that actually this is non-epileptic for the type of movement that the patient presents with or the duration of the seizures. They send the referral while they ask for an MRI and EEG. So we can do a parallel work because the evidence shows that actually the earlier you treat the patients, the better the outcome. If you leave it for longer, and we'll talk about that a little bit later, if you leave it for longer, the patients learn those abnormal patterns, and then it's much more difficult to change that pattern. When they elicit the secondary care, unconsciously, they're being cared for. And we all, when we are dealing with something that we are not aware of what it is, and nobody seems to be able to explain very well what it is, we seek more, isn't it? You seek for more consultations and different specialists because you want someone to come and tell you this is what you have. I think now there is more evidence and people are becoming more aware of the functional disorders. So we are seeing patients earlier that before. I have some patients that they come to me and say, well, 10 years ago I was, I have a girl who told me that years ago she was put in a cold shower as a treatment for the non-epileptic seizures because the way that was you're making it up. So it was kind of a punishment rather than a treatment. And I think in the last 10 years things have changed and there's more understanding of what's going on in the brain and what patients present with some of these symptoms. And I have sometimes patients where after 10 years it's very difficult, one, to change the neurological pattern, and secondly, to change the secondary damage that we have done to the patient. All of the things about not believing their symptoms, not believing how distressed it is. And I don't think it's anyone's fault. I think it's, this is how things have evolved and there was not enough tests or studies being done to understand what dissociative seizures were about. So first of all, you have the EEG and the MRI, and if you have, one of the things that's very important, if you take the neurological history, many patients may have known someone who has epilepsy, and again, unconsciously start reliving some of those things, or copying without copying it, but actually mimicking some of the symptoms they have witnessed when they're under distress. And then what I'm very interested in always trying to understand the neurodevelopmental history, how they were able to cope with stress, how many stressful life events they have. Most of the time in the past it used to be described that you have one traumatic event and then you will develop the non-epileptic seizures, so dissociative seizures. Well, now the evidence shows that you don't have to have one serious event. You may have a life of different traumatic events and then suddenly something happened and you start developing the symptoms. But it doesn't have to be that traumatic. It can be, I don't know, I was promoted at work. Sometimes patients come to me and said, actually, I was promoted at work. Something that should be nice, it can start creating more self-doubt and difficulties, and things that it should be positive end up being more traumatic and difficult because of the previous experiences of what they have in their life. Yeah. Then you want to know, do they have any family history of any neurological disorder or any psychiatric disorder? Most of the time, and you may be familiar with this as well, we ask patients to video record the episodes. It will help us, and again, this is because it's a clinical diagnosis most of the time. You will learn much more seeing the episode than what the EEG will show you or the MRI will show you. You pursue more EEG and ask for more if you see that the episode that you have seen in video or in vivo is something that you would think is epilepsy. And then the neurologist will ask for, well, maybe we need a 24 hours, or maybe we need, a whole weekend trying to monitor, or maybe we need a video telemetry when there are those doubts. Yeah. So if there's any doubt, and we have plenty of patients that we share with the neurologist that they may have epilepsy, but then they start developing other type of seizures that we suspect that may be non-epileptic, but it's very difficult because the patients doesn't video record that, they cannot remember what happened. So sometimes we do video telemetry because it's a gold standard. You can see the EEG in vivo and you can see how the patients presented, do they correlate? When they have these abnormal movements that they describe, that happens to them every day, does it correlate with the change in the EEG? If it doesn't, we are more confident that this is dissociative seizures. Yeah? Any questions? So this is a very bad picture. I'm really sorry. I need to change that, and I forgot. This is from Mellers, who is a neuropsychiatrist that I trained with, who is very nice. And he wrote this, it was to help students and other professionals to differentiate epilepsy and dissociative seizures. And what he described in this table is how to do the clinical assessment. For example, if you have arch backing, it's more commonly non-epileptic seizures. If you have non-rhythmic movements, it's more likely to have non-epileptic seizures. If you have prolonged seizures, more than 5 minutes, 10 minutes, 20 minutes, it's more likely to have non-epileptic seizures. All the kind of things that you know, but this is for people who are not that familiar with epilepsy. You see epilepsy all the time, and when you see one that is kind of off, you either call your colleague or you start doubting that this is not an epileptic seizure. Most people don't. So this is a nice way of remembering. If the eyes are closed, more likely it's not epileptic seizure. Those kind of things that it helps to diagnose people with non-epileptic seizure. And these are 2 videos that I usually show. I don't know if we'll be able to see it now. You see the eyes are turning to the left, staring. And then you have the tonic moment. Someone saw it and they said, actually, that's good, isn't it? Tonic. And start fitting. And you can see the rhythmic movements. I think you see this all the time, but Alexa and Paul, my psychiatry nurses, may not see that often, but it's nice to, you see quite rhythmical, you know, toon, 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 it happen. Yeah. And this is complex, the patient is unconscious. And so, yeah, you are all familiar with this one, you see them all the time. And this is someone that someone may have said, can you record when he's having one of these episodes? Pelvis thrashing is another thing that is typical of dissociative seizures. And you can see that here it's not as rhythmical, and the other one is not so sharp like the first one we saw. And then it stops and goes again, stops and goes again. When in the epilepsy, usually you go, and then when you stop the seizure, unless you start coming into a status. But again, the presentation is that type of pelvic, and I told you about the arching of the back is typical of dissociative seizures. Yeah, does it more or less illustrates the difference? Again, you say stop, and now it goes again. And the other characteristic is that the arms are not moving. One of the arms, you know, if you are moving both legs, you should be actually moving both arms in terms of how it works. But as you can see, the upper body is quite relaxed. Yeah. So, we saw these two things. You are more familiar with one of them. You may see the other ones, but actually saying, well, this is weird. This is not epilepsy, what it is. So what we know now that there is an abnormal function in the striato-thalamocortical circuit. Are you familiar? Striato is usually what moderates movement. Thalamo is a nucleus where it connects different parts of the brain from the cortical to the more lower part of the brain. And there is a separation between involuntary and voluntary movements. Yeah. So we know from many studies that actually, I put a lot of names in there, but actually what is abnormal in terms of what happened in fMRI studies, functional MRI studies, is that the limbic system is working differently what you would expect in normal controls. These are not comparisons with people with epilepsy, mind you, right? This is usually people with functional neurological disorders and people who are controls, who are normal, who don't have normal, whatever that means, who don't have functional neurological disorder. Yeah, they don't have any of this. So it's limbic system. And this is so beautiful. I don't expect you to remember any of these, but it's just to explain the complexity of what happened in the brain in patients with dissociative seizures. You have this limbic system, that this was actually designed by a neurologist who works in Queen Square, so who is interested in this kind of movements, Trimble. And what he describes is actually you have a lot of nucleus where receive emotions, memories, sensations, and they have to process all of that through your cortical area, and they need to decide in all of this processing what is important information that you need to keep, what important information that you need to throw away, and what is important information that you need to be conscious about or not. Basically, that's what the limbic system does. It makes us humans, and it makes us actually evolve and survive. Without the limbic system, we wouldn't have evolved. It's a system that actually helps us to fight or flight when we need it. Are you familiar with the concept of fight or flight? Yeah. So what it does is actually, it sees a threat and it tells you what you need to do. What happens with patients with non-epileptic seizures, with dissociative seizures, most of the time they will tell you, I freeze. They don't fight. There are people who actually get frozen when they're stressed, or they put everything under the carpet, they tend to tell you, well, I don't deal with that, or that's in the past, I don't have to deal with that. So that means that this system that is helping us to process all of the information is get cut off. We are cutting off this system that in some ways is helping us to evolve, it's helping us to adapt to circumstances and to events. So having seen all these complex system, as you can see, SMA is a supplementary motor area. So it's all linked with motor systems and conscious levels and unconscious levels. Unconscious sounds very Freudian, but it's not Freudian. It's just information that you store, but it's not always easily available. And I usually give examples to patients like, for example, you just listen a song and sometimes you start having a feeling in your chest, or you start saying, actually, and brings you back to a memory that you didn't remember that it was there. So this is what I call unconscious, is that information or memory that is not easily available unless there's a trigger. And that trigger can be a color, can be the shape of a person, can be a song, can be smell. Yeah? Most of us will see that and will actually immediately say, oh, that reminds me of when I was in my 50s and I used to go, 15s. And I used to go partying, and it was the song of the time. And some people, they have the emotion, but they don't recall it of what is related to. Yeah? And I will explain why that happens. So the theory has been going on for many, many years, but before we didn't have tools like fMRIs and EEGs and other cognitive tests to assess what was happening in this system. So what happened is you have a traumatic event, and that's what most of the things you will see the neurologists, I must say, trying to see if there has been any traumatic event or any difficulties while growing up, and most of the patients are positive for that. And some patients don't classify trauma, but actually they tell you that they have, I don't know, as brother or someone with learning disabilities. And again, you can see that I think they're not traumatic, but difficult, or they need to use extra resources that most of us may not have to use. So you will have this traumatic event or small repeated trauma, and then you will have the temporal lobe area, which is part of the limbic system, where we store episodic memory. You know, episodic memory is something that happened at one point. Most of the time, for that to get stored, you activate an amygdala. The amygdala is what actually is linked to emotions and stress and anxiety. So when these two get activated at the same time, your brain is saying, this is important information, keep it. Because it's this fight or flight type of system that tells you to help you to evolve. So when these two get together, that memory gets stored into your brain. Yeah? And then you will also have cortisol levels rise. And this is because of the stress response, the fight or flight. And you will see also in patients with non-epileptic seizures that they have abnormal cortisol responses if you test it for that. So this is how that memory and that trauma get stored. Then what happens is that most of the patients don't want to process that information and say, well, it's in the past, or my mom told me not to deal with that because it's in the past, don't make it a big deal. So all that information gets there, and then you start having aberrant connections, so abnormal connections, because your brain has that, it's an unprocessed, there's something that is actually, I don't feel right. And if you talk to people who have had trauma, you will see that actually they got through a period until they actually come to terms to what happened. They need to process that information. If that is not supported or help, then that information gets there, but it's not channeled into the right direction. And when episodes or things around life happens, go into a place that actually reminds them of that event, although they were having a fantastic party that day, yeah, then something happened that they cannot really recall. What happened is it may trigger these functional neurological disorders, and particularly the non-epileptic seizures or the dissociative seizures, because you have these connections where it was supposed to come into the frontal lobe, where you process risk and you process your information, you process what to do next, is what your executive functions, is what you measure what to do, is cut off. It's not there. So that information is going into motor systems. So you have, and sometimes I give this very simple explanation, but you have a system who's telling you run or fight, something physical, very active, and you're shutting it down. So that physical activity needs to be exposed. So what happens is come aberrantly, because you shut it from your frontal lobe, you're not letting explain what's going on, so it explodes. So it's like a pressure cooker. It's very basic, but I think it helps patients.
That's really interesting.
Yeah, I think it helps patients to understand if you don't allow this information to be processed, this system is prepared to run or to fight, to use your body, and you're not using it. So it's going to be expressed somewhere in your motor system. Yeah, because those connections are already there. Yeah. So that's all of those arrows and things that I put there, how it goes into different systems and how you end up going into the I always forget this SMA is supplementary motor area, and then you have this motor response. Yeah. And hence my challenge that it's not an organic thing. There are more and more evidence that actually these are abnormal connections that we don't, because we don't have the facilities or we don't have the tests yet to measure how these connections are made. But actually the evidence shows that actually there are changes, and there is more evidence from fMRIs where you have 12 patients who have conversion disorder and 12 healthy controls, and they are exposed to specific trauma with all cognitive tests that they do. So they measure both responses in the brain, and when you see is the patient with the dissociative seizures tends to have a hyper response on the frontal area, but low activity in the hippocampal area, which is actually where the memory is. So what you're trying to do, what your frontal lobe is telling you is don't think about it, don't think about it, don't think about it. Yeah? It's very simple, but I think it helps to understand what is this doing. And then you have an hyperactivation of the, again, SMA, supplementary motor cortex. So then you have this motor system that, well, if I don't want to think about it, I will have to do it. Yeah? And sometimes people say acting out. We all, when we get angry, the body responds as well. You either start shouting, or you start trembling, or you get red. So something happened in the body when you are trying not to process something. Yeah? Any questions? Does it make sense?
Yeah.
Yeah. And the interesting thing that actually they have also found that there is a reduction in the thalamus, so a smaller thalamus. It means that maybe this nucleus, and again, these are theories, this nucleus, that they're supposed to do a lot of very nice connections, start shrinking because actually it cannot do the right connections, so actually it's not working properly. But again, we don't know, this is secondary to the trauma or pre-trauma, because we are doing it only in people who already have the dissociative seizure. So it's very difficult to stipulate or to think if this is cause or consequence. But actually there's a difference for us to think about, that there's a structural change as well. Yeah. Again, this is research results. It's not that you can do an MRI on a patient and you will see that the thalamus is very difficult to measure. We don't usually measure it unless it's for research or unless you have a stroke. And again, you don't measure it, you just see that there's a lesion in there, isn't it? Okay. So, after we have understood a little bit more about the dissociative seizures, one of the things I usually recommend is that you need to explain what you think that they don't have epilepsy. So I think the neurologist and myself spend a lot of time, and some of you may explain, well, actually they're too long. Usually we don't have people with epilepsy have this long. Your movements are not the typical, and you try to reassure them that actually it's a good thing that they don't have epilepsy. Sometimes I think because it's better well known, they will rather have epilepsy. But more interesting, the patient who have epilepsy would rather not have epilepsy. So it's always that debate. But you reassure them that actually they do not have epilepsy, and you explain. And then what is very helpful is that you explain what the dissociation is, even if it's very basic. Most of the time what I do is you have this limbic system and I make a ball in the middle of the brain, I make a drawing, which is disconnecting to these other parts. And then I make the explanation about the pressure cooker. If you don't deal with things, at one point things will have to, start steaming out. And that's what happened with the dissociative seizures. Yeah, because we are trying to cut the connections. And in some ways, most of the time I said, oh, that makes sense. It's the first time that someone explained that to me. And that actually helps the healing process. In the same way that you tell someone, actually, you have a fracture. Yeah, it may be painful, but actually now I know that someone knows what to do with it. So that's quite therapeutic for the patient to know that there's going to be a solution or it's a treatment. So emphasize that they are not putting it on. Most of the patients come with that blame. Particularly, that's one of the limitations of accepting that they have dissociative seizures, because they think that people are going to think that they're putting it on, or they should be stronger, they should be doing something to prevent them. It is true that actually there is some level of control, but it's the same way that is some level of control, I tend to say, with people with epilepsy. If they don't sleep well, if they drink, or if they don't look after themselves, there's a level of control and they will have more seizures. If they get more stressed, people with epilepsy also have more seizures. So with the non-epileptic seizure or dissociative seizures, what you can try to do is to process the trauma. So that's the level of control, but it shouldn't be confused with actually you can prevent it. You cannot stop it. What you need to do is to treat it and process it. The treatment is different, but the patient cannot automatically stop because they know that it's not structural change. Yeah. So they're not mad. That's the other thing. When they see a neuropsychiatrist, they say, oh my God, they send me to the shrink. I must be mad, but it's not in my brain. I move, all of the things happen. They're real. They are real. They are happening all the time. And some patients actually stop going to work for months because they are unable to actually do the work. They are fitting every day, or they have periods of they need to recover for days. So these things are happening. So, and they're not mad. Actually, there is something that we need to work out in the brain. And then the other important thing, as I said, sometimes patients don't even remember a stressful period or trauma. I have some patients who come and said, well, actually, nothing happened. I just adopted 3 children with learning difficulties, and these are lovely. And I'm like, wow, that's a kind of life-changing event, and how you cope with it. It doesn't have to be stressful as you will experience. Sometimes people are expecting a rape or expecting, someone running over you with a bus. Sometimes can be smaller things that actually are changing your life and the difficulties that you're having. And it's about how we process those things. That doesn't mean they're ill or they're ill, but it doesn't mean that they're mad or these kind of preconcepts that they have. They just need to process things differently. Yeah. And then it's important to understand the etiological factors of each case, the trauma. As I said, sometimes because they adopted new children, sometimes because they were promoted. And the same system that helps you, and this is another thing I explain to patients, the same system that control emotions, which is the limbic system, is the system that will make you laugh and cry, and sometimes laugh and cry at the same time. And I give this explanation that sometimes you are crying and then suddenly you start laughing. And it's not that actually you're laughing of sadness. Sometimes people have said, I'm laughing, but actually I'm very sad. So it's the same system that is not actually found the explanation of what's going on. And that's why you have the other parts of your brain to give meaning to those emotions and sensations. And that's what you need to have with the talking therapy. Many patients improve after they have the right diagnosis and they're reassured that actually they don't have epilepsy, this is the treatment, this is what they need to do. And then you need to be careful about anti-epileptic medication. Sometimes patients have been placed on anti-epileptic, and when they start reducing it, they start having more fits. We need to bear in mind that anti-epileptic medication is also sedative. So this is one of the things that I usually explain to patients as well, that the sedative effect may be actually affecting how they're dealing with stress, and when you are reducing that, it may be more stress are coming out, or more difficulties or sleep problems, and that's what we not to think because we are reducing the anti-epileptic medication means that it's epilepsy. Sometimes it is, sometimes we need to be careful, particularly when we have high suspicions that it may be epilepsy. But just to bear in mind the other thing. And most of the patients I recommend, when they have non-epileptic seizures, dissociative seizures, I recommend psychotherapy. If they have comorbid anxiety disorder or complex PTSD or psychosis or other epilepsy, is when you add medication. Yeah. Medication sometimes can help and reduce the level of arousal, they reduce the level of distress and frustration that they have, particularly for depression and anxiety. I have patients that come to see me after 1 year of work, and of course they are already depressed and anxious and worried about going out on their own. So focusing only on the non-epileptic seizures, we are forgetting all the secondary damage that has been happening. Yeah. And I usually try to involve the carers, because one of the things, or one of the limitations, the carers of relatives, one of the limitations of patients recovering is the stigma and conception from the relatives of they're putting it on, or you can actually control it yourself, there's nothing wrong with you, why you have the thing. So when you give, and actually fascinated, because when you give this explanation about the brain and so on, and somehow it makes sense to them. Okay, there's something wrong with the brain. Okay, I cannot blame her anymore. And again, that's why my teasing at the beginning, where is this in the soul, in the heart? Because when people have these concepts, and it's difficult for me sometimes to explain, because it is linked to emotions, it is linked to many other sensations that happen in the body. But the final cure is how we control the emotions in the brain and the connections that happen. So the treatment begins with explanation of the diagnosis. And actually, I put here handed openly and sensitively because many patients don't accept the diagnosis at the beginning, and that's fine. We just need to tolerate. It's the same way you diagnose sometimes someone with cancer the first time. The first thing that happens is denial or anger. So we need to bear with that and help the patient to understand. Sometimes I get leaflets. I said, that's fine, I understand it's a difficult concept. Go read it and you can call back if you need more information. They need time to process it. We all want the medication that actually cures us, isn't it? You want the pill, you take it, and then you don't have it anymore. They don't know that you have epilepsy, you take the pill, and doesn't mean that you're not going to have epilepsy anymore. But in their mind, we all have that fantasy that you take one thing and it's going to cure you. So, and then we can use antidepressants if they have a comorbid psychiatric disorder, if we think that actually can help to reduce the hyperarousal or other comorbidities that they have. There's different modalities. The one that's mainly used is cognitive behavioral therapy, and I think we are part of the COAS trial. You're aware that we have a few patients they are looking at patients with non-epileptic seizures, and they're doing a course of CBT, and it seems that showing good results with CBT. Again, these are patients who are mainly purely non-epileptic seizures. They don't have much comorbidity. But then again, it works well for patients who have these presentations. We don't have it here in Southampton, but we are hoping to have something in the future. And then with this CBT, there is significant reduction in seizures in 6 months. And then actually one of the important things that I'm quite keen for these patients is they are able to go back to work and socialize. Patients may have no seizures, but actually has had such an impact in their life, or the stress that it's creating then creates more seizures, and they're going to this vicious cycle that they cannot go back to work with the worry that how people are going to think, or they think I'm mad, and all of those things. So, any questions? No?
Just a practical one.
Yeah.
What's the driving restrictions for non-epileptic seizures?
Well, there's no. I think there's something in the DVLA, and it doesn't actually specify how long you need to be without seizures for. Most of the time, what I recommend is about 4 months if they haven't had any, because you don't have a structure in it, you don't know the outcome. Some patients, after you give an expiration, they don't have any more seizures. Some patients will continue to have for years. So the longer they have, the more cautious you are when they can go back to drive. But yes. Do you see people with non-epileptic seizures? Yeah. And what do you usually do? How do you deal with that?
I think that's really interesting, the presentation you've just done, putting it into context of, yes, there might not be abnormal electrical activity, but it is actually the process in the brain, because I think it is quite easy for some staff on the ward to think, oh, they're non-epileptic, and people do have the misconception that they are putting it on, and I don't think it's just their family and loved ones that think that. I do think that some staff on the ward don't have the understanding of why it's happening, and so
it's very common to have that misunderstanding. That's why I'm campaigning for these things and showing some of the evidence, and little by little we will change. I think I have seen some shift into neurology and GPs and some other colleagues in the hospital of understanding that actually there's something. I said with non-epileptic seizures in the same way I said with other functions, or like pain or other things that actually they don't have structural change, but actually have a huge impact in patients' life. And it's more about how they process the body sensations and the body, the changes. So
we had a patient on the ward who'd had I think he'd been involved in a car accident about 5 years previously. He'd been given his diagnosis of epilepsy, and it was all post, his head injury and things like that. And when he found out it was dissociative seizures, he was mortified, and him and his family begged and said, do not ever tell. If anybody ever asks you, as in our family ring up, and please don't tell them it's not epilepsy, because it was them then saying they then felt that they'd lied to their family for the previous 5 years.
Oh yeah. We do have a lot of that, and sometimes I discuss with the neurologists how to break the bad news for them, because again I think it's related to the stigma with mental illness and this understanding that, well, if I have that I'm mad, it's just that link that people do straight away. And last week I was seeing a lady on the ward. I said, well, actually you're going to lock me up. That's the concept that they see when you're going to explain the things. Of course, after you give the explanation, I said, oh, actually that makes sense, thank you very much. And but we need to break that barrier, and I think with education and these things and the video is going to help to change some of those things. And the more evidence we have, the better. And if anyone has any question, or I'm always happy to discuss and think about these patients, because everyone has a different story, and how they deal with things, they do it differently. Today we spoke only about non-epileptic seizures, but actually it happened with functional neurological, so it's a similar model. Yeah. Anything else? Do you struggle working with patients with dissociative seizures?
I think not just dissociative seizures, but functional. Because we don't have, as adult nurses, we don't have any real background training in mental health and that sort of.
I think we need more
psychiatry aspect of things, and so. I think people are just a bit, I admit I'm a bit ignorant when it comes to mental health type issues, not just this but everything, because we just haven't really had much.
Well, but that's why I like these
so it's
initiatives of trying to neurology and psychiatrists, we share so many things, and I think the two departments that we are trying to work and do more teachings together and trying to join the things, particularly because patients are becoming more complex. They go into the internet, they find a blog, and then they have with more symptoms, and what we told them is not epilepsy seizures now. The other day I have a patient who told me very proudly I have functional neurological disorder, and I belong to this group that they all have functional neurological disorder. And in some ways I think it's good, but on the other hand they just feed each other with different theories and things. So if you are aware when you have those patients, then you will be able to correct some of the theories that they get from the blogs. I support them because at the same time I feel they feel isolated. Nobody talks about functional neurological disorder, so if they feel they can belong somewhere, they can talk freely about these things, it's great. It's about how we support them in moving forward rather than being stuck into this, I belong here, I belong to this ill group. There's more, actually, patients can recover very well. Yeah. And you know where to find me, so you can always call. I cannot always come straight away, but I'm always answer the phone at least. Yeah. Okay, well, I hope that this video helps to share the knowledge and everybody knows how to find me. Thank you for inviting me.